Well, today we have Dr. Trivedi. He's practicing in Varanasi. We also have Dr. Tarun Gupta. He's also practicing in Varanasi. And we have Dr.
Jindhal.
We have Dr. Jindhal. He is also practicing in Varanasi. Well, we'll be talking about OAB, which is a very prominent problem these days. We have doctors in the house and they'll be talking about the problems and how we can overcome this sort of problem, which is very persisting. Very welcome, all of you.
Thank you.
We're going to start with Dr. Samir.
Sure.
Can you please describe for the audience viewing this, what is an OAB? I mean, there are people who feel like it's the matter of age and anyone can have it and then it goes by its own. So what is an OAB for a matter of understanding?
That is the biggest fallacy, that the myth that one can have, that it's an old age problem and so it's certainly not an aging problem, it's a disease. And basically what it means is a person loses the control of his voiding or micturition or urination, which means he or she gets a very sudden severe urge to pass urine, which is abnormal, and he is not able to control the urine, and in severe cases he may actually leak out urine in his clothes, so there may be bedwetting. This is a layman's definition. For us as urologists, we go by scientific definitions, which would be mainly the presence of urgency. This is called an urgency.
Okay.
Inability to postpone your urge to pass urine. So urgency is the cornerstone. Along with that, because of this urgency, a person has to go again and again to pass urine, which is called as frequency. So urgency, frequency, and getting up many times in the night to pass urine, which is called nocturia. These three symptoms together are the cornerstone for diagnosis of OAB. But the main symptom is urgency, that is inability to postpone the urge to pass urine.
Well, doctor, would like to ask you, are there any causes behind OAB? I mean, there are people who think, what are the causes, how we can prevent it? So, are there any hidden causes we need to know, or what it is?
There are causes, and the OAB is defined according to the primary cause at times. Now, it can be like, for example, neurogenic bladder. So, somebody who's got compression, the nerves are getting compressed, that could be a reason where you get certain stimulation for the bladder to generate a pressure which makes a person to be unable to hold the urine. The other causes, which is very common in India, is again diabetes mellitus. The patients who are diabetic often always present with symptoms of frequency, as Dr. Samir said, and urgency, and that's how we pick up diabetes in some patients who present with severe urinary symptoms and getting up to pass urine up in the night. And the other common problem again is with aging, as the prostate enlarges, which results into a secondary overactive bladder. So there are numerous causes, and that's where the urologists come into play, who assess the symptoms, evaluate the patients, and then investigate them accordingly, and then treat them.
Anything would you like to add?
Yeah, it's one more factor.
Yeah.
Apart from this, what Dr. Tarun has said, infection is one of the cause where bladder becomes irritable and the symptoms are like that. So we have to investigate and we have to differentiate between whether the patient is having symptoms because of infection or it is not because of infection.
So we need to actually evaluate the patient first, and then we can get to the conclusion. Well, there are times when the patient delays the process of getting a consultation. They do not go to in the early stages, and now they go to the doctor when the water is overhead. So what could be the complication, the severe complication a person might need to face if they are delaying the process?
Well, I mean, if you have something which is irritating in the bladder and causing the symptoms, say for example, a sort of tumor growing inside the bladder which might cause these symptoms. Now, these symptoms are a common group of symptoms which the patient may present with. As I said, it is important, the reason behind it has to be evaluated, which is done in a step-ladder fashion. You have to go stepwise to evaluate these patients, and unless until you go and present yourself to a qualified urologist, these will be missed, and then obviously it will be picked up on a very late stage when it may not be amenable to a curative treatment.
Well, if a patient is coming in the early age and early stage of the problem, is it curable, it is controllable, it is reversible?
Yeah, see, as we have been discussing, whether it is secondary to any cause or whether it is primarily an idiopathic OAB, in which there is no apparent cause. If there is a cause underlying these symptoms, you treat the cause, these symptoms go away. If there is no cause, it's primarily an OAB, disease of the bladder, then there are very effective treatment options. Starting first, we advise the patient certain lifestyle changes, certain behavioral modification, some physiotherapy, exercises, advice regarding fluid intake, which beverages to avoid, avoid excess of caffeine, tea, alcoholic drinks and so on. And that doesn't work, then patient goes on to the second stage, which is treatment by drugs, pharmacological treatment. There are excellent drugs available these days which have got very good therapeutic response, and most of the patients do respond very well to such medications. Some patients, however, do not either tolerate the medicines because of side effects, or sometimes the drugs do not work the way we expect them to, in which case the third line options are basically targeted to decrease the nervous sensitivity of the bladder, which would mean it can be in the form of electrical stimulation, it can be in the form of injections directly into the bladder, specifically the Botox injections, and then there are certain neuromodulation techniques which can be used. So there are, as you said earlier, it's a step ladder kind of treatment. You start with the most basic and most easy to follow treatment, which is lifestyle and behavior, then you go to drugs, then you go to these interventions, and lastly, when everything else fails, you can operate and increase the size of the bladder to make it hold larger amount of urine.
Well, if in case somebody is not looking forward to have the stage 3 of things, they need to rush to the doctor as early as they get to know. Because as early you reach to the doctor, it's there are possibilities to get it recovered.
The efficacy of every treatment increases when it is done at an earlier stage.
Yeah. So Dr. Jindhal would like to know, I have heard the term called behavioral therapy. Now what it is, because there are patients who know what is, they know about the term, but they do not know what is behavioral therapy and how it can help them.
Yes.
Yes, sir.
Most important is exactly these patients have a frequency. So, as far as behavioral part is concerned, one has to suppose I have an urge for wedding. So initially I have to take hold it for a more period of time. Then you have to gradually increase the time period. So in that way you have to train the bladder to hold the urine. Every time suppose you have an urge and you rush, then definitely your bladder will remain in the same status.
Yes.
But if you have to increase the time gradually, sometimes you increase by 5 minutes, then 10 minutes, then these behavioral changes also have an impact on the final outcome and treatment.
Well, the last question would be from all of you. Anyone can answer this question. Well, there are people who say that this is a psychological problem, and if we get a control or if we lead our psychology, this problem can be controlled or reversible. Is it?
I personally feel that psychological problem is the outcome of the disease, not the cause of the disease.
Actually.
Everyone, if he has to pass 20 times and have to rush to the bathroom, that gives the impact of psychological. But primarily, I don't think that psychology is the cause of the symptoms.
Is there any lifestyle modification a patient can do?
Yes.
In order to avoid this?
Ideally speaking, when these patients come to us, we ask them to make what is called as a voiding diary.
Yeah.
We give the patient a kind of proforma, which he or she has to fill by herself at home. And this diary basically tells us during the course of 24 hours how much liquids or fluids that the patient has been drinking and which kind of liquids he or she has been drinking. It also has to record how many times, at what time did the patient go to pass urine, how much was the amount of urine passed. These two things give us an idea about the patient's total fluid intake and total output along with frequency. Based on this, we decide that the patient's fluid intake is inappropriately high. Then we'll ask him to cut down on fluids. If certain types of fluids are triggering these urges, for example, he has had a glass of some particular type of juice which his body is not tolerating, and then he has to go to pass urine 2-3 times rapidly in succession. Anything which irritates the bladder in the diet, which may be edible food, it may be a liquid. So we look for those clues which provoke these kind of things, and we ask the patient to avoid those things.
Yes.
So dietary advice is one aspect of lifestyle changes. Second is physical fitness. Obesity, sedentary lifestyle, all that contributes to OEB as well. So the patient has to be asked to maintain a healthy lifestyle, exercise regularly, cut down on the weight if he is overweight, and then taking the type of irritants like smoking. Smoking or tobacco is a direct irritant to the bladder. It can also produce the urge to void. So all these things will fall in the purview of lifestyle changes. So that will vary from patient to patient. It needs a very detailed and thorough history taking, and based on that these advices are offered.
Anything you would like to add? Or this is...
So,
Yes, sir.
I always ask the patient, what does he do for a job or the profession?
Yes.
If somebody is a taxi driver, somebody is an auto rickshaw driver, somebody is a banker, are more likely to have nicotine or nicotine-related products.
Yes.
So a banker would be drinking more coffee during his working hours.
Right. Right.
So those are the things that you have to have, as Sami said, to have a very detailed history. Sit down with them, tell them what triggers it off.
Actually, it's not only about treatment, it's about counseling the patient.
Absolutely.
Yes? Well, thank you so much, gentlemen. It was very amazing talking to all of you. Have a great time. Thank you so much.
Thank you so much. Pleasure.
Thank you so much. हेलो ऊपर ऊपर आ जाओ ये